I'm Dr. Rita Roy, CEO of the National Spine Health Foundation. It's a real honor for me to be here today participating in this remarkable collaboration with our colleagues and panelists, our friends at the Focused Ultrasound Foundation and the Breast Cancer Alliance, and all of our panelists. The Spine Health Foundation is dedicated to improving the lives of those suffering from neck and back pain. There are about 100 million Americans who suffer every year. That's 1 in 3 people. Back pain is the leading cause of lost work days and the #1 reason for opioid use after cancer treatments. Neck and back pain debilitates people, causing them to not only lose work, but to lose out on life. Our purpose is to give hope that you can overcome your spinal challenge and get back to the people and activities you love. We do this at the foundation by educating Americans about proper spinal health and by conducting clinical research to discover which treatments give the best outcomes. The spine, so naturally, many other conditions can affect the spine and lead to pain. Today, we're going to hear from experts who are innovating better and better ways of treating and curing pain. We'll be taking questions from the audience, from all of you, for about the last 10 to 15 minutes of this hour. Please submit your questions through the chat to Yonni, and Yonni will collect them for our moderator. Speaking of moderator, it is my privilege now to introduce Dr. Natalie Azar. Dr. Azar is an NBC News medical contributor responsible for covering all major breaking medical news stories for the Today Show and MSNBC. Dr. Azar has been nominated for a prestigious Emmy Award for her work at NBC News. Dr. Azar is also a practicing physician. She's an assistant clinical professor of medicine and rheumatology at the NYU Langone Medical Center in Manhattan. In her busy private practice, she sees patients at both the Center for Musculoskeletal Care and at the Joan H. Tisch Center for Women's Health. Dr. Azar's expertise is in the field of arthritis and autoimmunity, and she specializes in rheumatoid arthritis, osteoarthritis, fibromyalgia, osteoporosis, and more. Dr. Azar received her medical degree from Cornell University Medical College, where she graduated with honors. She completed her internship and residency at NYU Bellevue and her rheumatology fellowship at NYU Hospital for Joint Disease. Dr. Azar's collaborative approach to the rheumatologic care of her patients includes a team of practitioners, including physical therapists, acupuncturists, orthopedic surgeons, and multiple other subspecialists. This ensures the best comprehensive care for her patients. And with that introduction, I turn it over to Dr. Azar.
Thank you so much to Yonni and to you, Rita. Dr. Roy, I really appreciate it. It's such an honor to be here with this distinguished panel. And I know that anyone who has logged on to it is very excited and eager to hear about all of these different advances in the treatment of spine pain. I know I certainly am, as I see this so much in my own practice. So the way the hour is going to work, we are going to do introductions of our panelists. I will introduce each of them individually, and after I make the introduction, they will give you a few minutes an overview of their area of expertise and their specialty. And then after that, I'm going to be posing some questions to the panelists, and we'll sort of have a little bit more of a didactic conversation, and we'll save viewer questions for the last 10 minutes or so. So without further ado, I'm going to introduce one of our panelists, the first one, Dr. Niteesh Bharara. He is the director of Regenerative Medicine at the Virginia Spine Institute. He has redefined outpatient treatment options for athletes and active individuals suffering with spine or orthopedic conditions. Dr. Bharara is leading the Mid-Atlantic region in performing effective natural therapies such as stem cell therapy, PRP, prolotherapy, and lipogem injections. He has been named the 2020 Face of Regenerative Medicine by Washingtonian Magazine. Dr. Bharara?
I'm Niteesh Bharara. I'm a physical medicine rehab doctor that takes care of a lot of acute and chronic pain. I specialize in regenerative medicine, and today I'm just going to really quickly discuss regenerative medicine for orthopedic conditions. So this is a very broad topic. So I'm just going to touch on the basics on it, and then we're going to have some time for some questions. So let's get into it. So as mentioned before, musculoskeletal pain, the most common cause of long-term pain and physical disability, really affects millions of people worldwide. And at any one time, 30% of adults will have some sort of joint pain. And breast cancer patients are actually 25 to 50% more likely to experience some type of joint pain for a variety of reasons. It could be they're also from their cancer medications. So we've all had orthopedic issues and injuries. And as we've all heard, the first thing you always do is you rice it, you rest it, you ice it, you compress it, and you elevate it. And then if that doesn't work, you can try some other things like anti-inflammatories or steroid injections or physical therapy. But all of these treatments really just get down to treating the symptoms. Nothing is really treating the underlying problem. So that's where regenerative medicine comes in. So regenerative medicine actually fixes and treats the underlying injury. And so how do we define regenerative medicine? Well, it's simple. This is a field in medicine in which we use our own body to heal itself, and we want to restore function and reduce pain. And to really understand regenerative medicine, you have to understand how grass grows. So so to grow grass, we need seeds. We need fertilizer. And that's the same thing we need in our body to grow tissue. So when we have a lawn that maybe has some sparse grass, sometimes we can just kind of put a fertilizer on the area and get that grass to grow. The same thing on the orthopedic injury area. So if we have an injury that's maybe a mild injury, and we just need to kind of get that tissue to start growing, sometimes we can just kind of put that fertilizer on the area of the injury or growth factors. And that's equivalent to something called PRP or platelet-rich plasma. But sometimes that lawn is really is not doing well at all. And sometimes we need to place some seeds there to get the grass to grow. And when we want to do that with an orthopedic issue, we would want to put cells or stem cells at the area of the injury to help the tissue grow. So growth factors are equivalent to something called PRP, and stem cells are equivalent to something like the seeds to get the grass to grow. So just as I mentioned, the fertilizer is also equivalent to PRP, and PRP is a product that we get from your own blood. So we get the growth factors out of your blood and we place it back into the area of the injury to get it to supercharge that healing process. And sometimes if the injury is more severe, we would use stem cells or the seeds to get that tissue to grow. And we can get that stem cell from the patient's own bone marrow or their fat. So like I mentioned, when somebody needs a PRP injection, this is where we take their blood, we separate it, we take the platelets out of it. The platelets are where all the growth factors sit. And then we mix it with some plasma, and that's called platelet-rich plasma. And so we can place that specifically back to the area of the injury to kind of fertilize the area and get that area of injury to start healing. Sometimes we need stem cells. So that's where and stem cells are cells that can turn into any type of cell. So this cell can turn into a tissue cell or a nerve cell or a muscle cell. It can turn into any different type of cell. So that's why they're extremely interesting. And it's really important to understand we're not using embryonic stem cells in this situation. We're actually using something called adult stem cells. And it's really important to understand the difference. Embryonic stem cells are very controversial, and they have the potential of turning into maybe tumors or other issues. So we don't want to use those at all. We want to use adult stem cells, which can only turn into a few different types of cells, including muscular cells or bone cells or nerve cells. So they are very safe, and through many studies, we have shown that they have no chance of developing cancer or really any other issues. So it's an extremely safe treatment option. And so we can get these stem cells from different areas of the body. We can get them from the bone marrow. We can get them from the fat. And so, and there's some other places as well, but they're very highly concentrated in bone marrow or fat. And when a patient comes in for a stem cell procedure, we take some bone marrow from their hip and we separate the stem cells out of it. And that's what we place directly back into the area of injury. Or we can do a liposuction, get the fat out of it. We process that fat, get the growth factors as well as the stem cells out of it, and place that directly back into the area of the injury to get that orthopedic injury to start healing. So we treat a variety of conditions with both PRP and stem cells. We treat arthritis in many different joints, like the hip, the shoulder, the knee. We treat ligament issues like the ACL. We see tendon issues like tennis elbow. We do it a lot in the spine when you have a disc problem or a joint problem in the back and you can't move very well. It's very commonly treated there. Or if you have a muscular tear, we can also use regenerative medicine, and it works very well for many of these diagnoses. So that's just kind of touches on the basics of regenerative medicine. I'm going to be happy to answer any questions that come up, and we're going to have some questions a little later on in the presentation.
Thank you so much, Dr. Bharara. The next panelist I'd like to introduce is Dr. Alka Gupta. She is the Chief Medical Officer and co-founder of Bluerock Care, a new primary startup caring for seniors in underserved areas. As she seeks to make excellent, comprehensive primary care feasible for all seniors, she believes that prevention and a healthy lifestyle should be at the forefront of healthcare. A clinical assistant professor of medicine at Weill Cornell Medicine in New York City, she was previously co-founder and medical director of the Integrative Health and Wellbeing Program at New York Presbyterian Hospital. Dr. Gupta is board certified in internal medicine, lifestyle medicine, and integrative medicine. Dr. Gupta?
Hi everyone, and thank you, Dr. Azar. I think the term integrative can be a quite confusing term for a lot of people, and it's sometimes used differently. So, I'd like to take a couple of minutes to just chat about that. I got interested in integrative and lifestyle medicine during my training, which I did in internal medicine, because I was taking care of a lot of people with complex problems, and I felt like I couldn't take care of them as fully and as completely as I really wanted to. So, as you might expect, internists take care of patients with pain, with heart attacks, other serious problems, and I was getting questions that I couldn't fully answer. Now, integrative medicine is quite different from alternative medicine, which became popular in the US, especially back in the 50s and 60s, where people were using non-evidence-based medicine instead of standard of care. Now, we know that leads to poor outcomes. And so from there, complementary medicine became more popular, where somebody might, for example, see a primary care doc for maybe back pain, and then maybe they'll go and seek out additional therapies somewhere else to help. So, for example, acupuncture, let's say. Now, it's better than alternative medicine because you're not choosing one thing instead of standard of care, but it can still be a little bit disjointed. The right hand is often not talking to the left. And if somebody's using something with not a great side effect profile, that can lead to poor outcomes as well. In integrative medicine, we really strive to bring in evidence-based therapies that you might not typically find at a hospital system or a regular medical practice into that setting so that people who could benefit from it can have access to that sooner, perhaps, than before. And really, I consider integrative medicine an approach. It's a way of looking at a problem and trying to determine what is causing it, what's contributing to it, kind of like Dr. Bharara was saying, addressing the underlying problems with the goal to achieve a better outcome. We can take maybe one common example, like irritable bowel syndrome, which is a very common condition here in the US, essentially where somebody has irregular bowel habits or abdominal discomfort, and we don't have a great answer for why, and it doesn't fit into a specific diagnosis. One approach I often see is, using stool softeners or laxatives or maybe medications that decrease spasm. But on the other hand, we know that what we eat and drink, how we move, stress, sleep, these things are really impactful in IBS. And so a second approach that might be more effective and more long-lasting would be one that addresses those underlying factors. In the same way, for somebody with a history of breast cancer, it might make sense to think or talk about nutrition, physical activity, and the same. The NIH has an institute that's that's dedicated to describing the science behind an integrative approach. And now most academic medical centers in the US also contribute to integrative medicine in some way, whether it's clinically or through education or through research. So I hope that's some helpful background, and I look forward to talking more and answering some questions later.
Thank you so much, Dr. Gupta. Next, we have Dr. Suzanne LeBlang. Suzanne is the Director of Clinical Relationships of the Focused Ultrasound Foundation, where she interacts with preclinical and clinical researchers around the world to expedite clinical adoption of this novel technology. She has performed hundreds of focused ultrasound procedures and is also a breast cancer survivor herself. Dr. LeBlang?
Thank you so much for the introduction. So I'm very excited to talk to you about this technology called focused ultrasound. And the Focused Ultrasound Foundation puts out a State of the Field report every year. And you can see the numerous ways that focused ultrasound can affect pain and help treat pain. So bone metastasis, as you can see here, already has regulatory approval. And then we can also treat other causes of pain like, said, arthritis. Now, how does this work? Focused ultrasound, it sounds very complicated, but it's really not. So do you remember when you were young and you used to go outside with a magnifying glass? You can make the sun's rays converge at a focal spot on the leaf, and it will actually catch on fire. You generate very high temperatures. But if you put your hand in between the magnifying glass and the leaf, nothing will happen to your hand. So how can we do that with focused ultrasound? Instead of using the sun's rays as the energy source, let's use an ultrasound beam, just like the ultrasound you use when you're pregnant or when you're getting your gallbladder looked at. So let's see what happens when we can do it inside the body. We can put a patient inside a focused ultrasound machine. You can see the beam here coming down from the bottom, and we can use the MRI scan or ultrasound to guide this to a lesion inside the body. And when we direct that beam there, we can generate very high temperatures and ablate tissue. But all the tissue in the interim is completely left intact. So it's a very interesting technology that we're really, really excited about in the field of medicine. So how can we use this to help breast cancer patients that have bone metastases? Bone is the third most frequent site of metastatic disease in breast cancer patients, most common cause of cancer-related pain. Hundreds of thousands of patients suffer from bone metastases every year. Many of them end up getting external beam radiation therapy, and not frequently, only a third of them will not respond to that. So MR-guided focused ultrasound can actually offer numerous advantages compared to conventional external beam radiation. Number one, the pain relief happens almost instantaneously within 1 to 3 days, whereas radiation therapy can take a few weeks. You only need one session with MR-guided focused ultrasound to make the pain go away, and oftentimes you need multiple sessions of external beam radiation. There are multiple side effects with external beam radiation and very few with focused ultrasound, and it's repeatable because we don't use radiation, right? So let me show you an example. Here's a 36-year-old breast cancer patient. Her VAS score, which is a pain score, was 10, which on a scale of 1 to 10 is the highest. So here you see part of the ileum here, and you see a enhancing lesion, which is causing tremendous pain. After the focused ultrasound procedure, there's a black band here along the surface of the bone, and the nerve resides along the surface of the bone, and that nerve causes the pain. So what we're actually doing is ablating or killing the nerve so it won't send those sensory signals to the brain to tell you you have pain. So again, the beam comes down from the bottom of the table, we focus it right to the area, and then before the procedure, you can see that there's this lytic lesion in the bone, that's the tumor in the bone. And what they've also found is that the focused ultrasound procedure promotes healing. You get recalcification of the area to make the bone strong again. So number one, it gets rid of the pain, and it also tends to help heal the bone. And randomized control trials proved this, and these are just some data in case you wanted to look up the results of this randomized control trial that led to the FDA approval. How else can we help breast cancer patients with focused ultrasound? Well, a lot of patients get breast cancer when they're older and they already suffer from degenerative disease. And patients are living longer because our breast cancer treatments are so good. So patients such as myself, I'm now 5 years out, are living 5, 10, 20 years or a lifetime and being cured, and then will suffer from arthritis. So one type of common arthritis is facet degenerative changes, where the joint more towards the back of your spine rotates and causes degenerative changes. And the current standard of care treatment is RF ablation, where you stick a needle right next to the joint, as you can see here, and you ablate the nerve. Again, you want to kill that sensory nerve. So think about how we can do this now non-invasively with focused ultrasound. Oops, sorry. So again, here's RF ablation, where they stick the needle into the back to get to this little yellow nerve right here called the medial branch nerve. So now you can picture with a focused ultrasound machine, we can do this completely non-invasively. We put an ultrasound transducer on the back, shine the ultrasound beam right to the same exact location where the medial branch nerve is, and ablate the nerve that way. In this upper picture here, you can see the damage to the soft tissues caused by RF ablation. But in the bottom picture over here, you can see that the focused ultrasound machine only ablates the nerve exactly where it resides, very close to the spine. So those are two areas that are in clinical use right now. I wanted to just give you a little teaser as to what's coming up on the pike. Many patients suffer from disc disease, breast cancer patients, non-breast cancer patients. But there's ample preclinical data now that's investigating ways that focused ultrasound can actually stimulate collagen production inside the disc to make it strong again, and also deliver drugs in a targeted fashion in a non-invasive way to the disc space to help alleviate pain and or promote more collagen. So you can put different drugs inside these particles, and then you can use the focused ultrasound machine to release the drug in the disc space. And then that drug can affect the disc space right there and nowhere else in the body. So it's like a targeted drug development tool. And also it stimulates collagen production. So we're very excited about this area and hope to bring it into clinical research soon. So I hope from that short talk, you know a little bit more about focused ultrasound. Our website is listed here, fussfoundation.org. And again, we're using it clinically right now for pain palliation from bone metastases and for degenerative changes in vasecogenic back pain. So thank you for your attention.
That's wonderful, Dr. LeBlang. Thank you so much. And last but not least, we have Mr. Ethan Ruby. He is a successful entrepreneur and pioneer in the medical cannabis industry, having helped thousands of patients suffering from debilitating pain conditions. After graduating from the University of Pennsylvania, Ethan co-founded a successful New York City day trading firm. His life changed dramatically in 2000 when he was hit by a car, leaving him a T6 paraplegic. Ethan founded Theraplant after realizing traditional approaches to paraplegic pain relief were incompatible with high-level functioning. Ethan?
Thank you all. Thank you, Dr. Azar. It's an honor to be here and speaking to you, and it's finally to be able to consider medical cannabis in the realm of alternative therapies that are legitimate. I've been doing this for over 10 years now, and the medicinal properties of this plant never cease to amaze me, and I'm so glad to be able to contribute what potentially could be some pain reduction for patients in the context of all these other healthcare professionals. So thank you. All right, cannabis and pain management. I do disclaimer, cannabis is still considered a class 1 scheduled narcotic with no medicinal value. As was mentioned, I am the CEO of Theraplant, or I was the CEO of Theraplant. I am the founder. Clinical research is still limited, but there needs to be much more out there. The anecdotal studies or the anecdotal information that is out there is there's a tremendous amount of beneficial effects for both acute pain and chronic pain for people dealing with breast cancer or any ailment. I did find this slide that I wanted to put in here related specifically to breast cancer, that breast cancer patients have found significant benefits using medical cannabis in their either treatment of the cancer itself or to deal with a lot of the side effects that come with either chemotherapy or radiation. But unfortunately, to date, there still are not studies that directly go after the effects of various cannabis in different ratios specifically for breast cancer. Hopefully that will be changing soon. Won't go too much about it. Everyone knows what the difference between acute pain and chronic pain. The only thing I want to mention about acute pain is that if we can get to treating the pains effectively and dealing with the underlying cause, then you can prevent acute pain from becoming chronic pain. Therefore, the opioid addiction and other problems that come with prolonged pain medication can be stopped before they even get started. So how does cannabis work in our body? This was something that was new to me, that I learned over the last decade, that we have an endocannabinoid system in our body. We have receptors all the way from our brain down to our muscles and our toes. These receptors are responsible for things such as immune function, digestion, memory, inflammation, and pain control. The endocannabinoid system works by having different endocannabinoids, the cannabinoid receptors, and the different enzymes that trigger them. I am not a doctor, although I have played one on TV a few times, but my entire family is doctors, so I have a little bit of information about this, but I certainly am not a medical professional. Cannabinoids are the active compounds that are found in cannabis that directly interact with the cannabinoid receptors that are found throughout the body. I can't go into all of them now because we are limited in time, but I will talk a little bit about the main ones that we hear about: THC, THCA, CBD. THC is the main active ingredient that does produce the psychoactive effect, that high feeling that people can experience. Same with the THC, one is activated and one is not. CBD is available, I think, through Amazon now. You can buy it from any store. It can be shipped to you directly. CBD does not contain any of the active ingredients that give you the psychoactive effect, so it will not get you high. But CBD does show beneficial effects in terms of inflammation. So it is something to consider outside of THC if you're worried about the psychoactive effects or getting high. Terpenes are really responsible for some of the different feelings associated with taking THC, THCA, or CBD. THC and CBD are just the cannabinoids, but the effect of feeling either elated or more docile can really come from the terpenes that are in each plant. So if you're using the raw material plant, that it becomes very important in your selecting strains. When we're talking about extraction, where you can pull the specific cannabinoids out of the plant, this becomes really important because you can actually create a specific ratio of cannabinoids and terpenes to cater towards a specific effect. If it's appetite suppression, if it's appetite stimulation, if it's pain reduction, if it's for migraines, etc. The entourage effect is something that you may or may not have heard about, and this talks about combining CBD or combining THC together with the other cannabinoids. So if you're taking CBD, just CBD, yes, there will be a benefit. If you're taking THC and just THC, yes, there is a benefit, but there have been studies showing that the effect of combining these two things together has a much better result for what you're looking for. I believe it has something to do with the membrane of the cell wall and having better absorption of the different cannabinoids. But again, I would probably leave that to somebody more medically trained to explain. I did want to briefly just touch on, we're talking about alternatives to pain management. We've all paid attention and know about the opioid deaths that are plaguing our states, our towns, our communities. Keeping people off addictive opioids is very important. And when you're using something like cannabis that is not physically addictive, that has had no fatalities and overexposed death, we're talking about a much more mild medication that can hopefully stop a lot of the problems when it comes to long-term pain management that sometimes can develop. Again, the goal of cannabinoid-based drugs is to find and discover the medicinal properties in them. There's more and more studies that are being done. There's more and more studies that are needing to be done. But at this point in time, as opposed to 10 years ago, it's undisputable that there's medicinal value in these plants. There needs to be more research. My advice with you in consulting your healthcare professional, whether you're dealing with brain cancer, breast cancer, or any other types of ailments, ask the questions, know your options, make educated decisions. There's a lot of information out there right now, and I encourage you all to seek it out. So I thank you for your time. I did, as somebody asked me to throw in a picture, this is what one of our grows looks like with flowers that are about to be harvested. Natural medicine. And this is part of our extraction room where some of the medicine is turned into specific formula ratio. That is a CO2 extraction machine that can separate out the different terpenes, cannabinoids, and then we can make different ratios depending on the different ailments we're trying to treat.
Thank you so much, Ethan. I'm wondering if anybody else is feeling like we could literally have a 4-hour-long webinar on this, because each topic deserves so much attention, and I'm sure I hope everyone else is finding it as informative as I am. So what we're going to do is try to integrate some of the viewer questions with some questions that I had planned to ask, so that we can try to get to everything by the end of the hour. So this first question is going to go to Dr. Bharara. One viewer wanted to know whether age has any impact on the benefits or the outcome of you doing PRP. And then I'm just going to tag on another question. Who performs the regenerative medicine procedures? Is it orthopedics? Can anybody be trained to do it? And I'm just going to throw in there, is it still not covered by insurance?
Yeah. So these are all good questions. We'll start off with the first one in terms of age being a factor in regenerative medicine, and they mentioned PRP. So age is a factor in healing in general. However, with PRP, it's not as big of an issue. We're more concerned about the severity of the injury. That's really what we have to decide and what we're trying to treat. There are some injuries that seem to lend better to regenerative medicine and have more success than other injuries. When we're talking about stem cells, as you get older, we are seeing less and less volume of stem cells in bone marrow as well as in fat, less in bone marrow than in fat. So as you age, we are seeing less stem cells. So we would have to harvest more to get a higher concentration of stem cells. So we do take into account age when we are treating an issue. However, when we're doing regenerative medicine, as you get older, the healing potential drops slightly. So we are seeing that younger people seem to do better for many different regenerative medicine procedures. But that's not always true. There's been some studies that have looked at treatment of the use of PRP in knee pain, and it's not really dependent on age. It's more dependent on how severe the arthritis is in the knee joint, and then the actual approach to treating the knee with the PRP. So I think that's more of an issue. Now, the next question was about cost and about insurance coverage. So so in the past, there has been this thought that many of the regenerative medicine procedures aren't evidence-based, and that's really not true anymore. We have a significant amount of evidence that have shown regenerative medicine to actually be far superior to steroid procedures that are covered under insurance, as well as in the knee gel injections. And I was going to put a couple of slides in about some of the evidence that we have. We also have seen it to be much more effective in the spine when we're treating degenerative disc disease. We have a couple of studies that have shown it to be extremely effective in the disc that we have recently published and we've presented on. So the idea that it's not evidence-based is not true. And insurance companies are actually starting to pick up the use of PRP for many different conditions. So, for example, TRICARE now covers regenerative medicine, and specifically PRP, for osteoarthritis of the knee. They cover it for tennis elbow and lateral epicondylitis. So as time goes by and as insurance companies now start reviewing the evidence that we do have for regenerative medicine, I do believe it is going to become much, much more mainstream and going to be covered under many different insurance plans.
Awesome. Wonderful. Thank you so much. So this next question I'm gonna throw to Dr. Gupta. It relates to the relationship between tamoxifen and joint pain. So I'm wondering if you might be able to address that, but then more broadly, can you just talk about how it's possible for patients to be able to get pain relief using less conventional modalities?
A lot of patients who are going through treatment for breast cancer can experience joint pains. It is a bit more associated with a different class of medications, the aromatase inhibitors. But, we've certainly seen people who experience similar symptoms with tamoxifen. Some people find there is some evidence showing that exercise and actually utilizing joints is probably a better idea than getting less active, which is more often the tendency. And then some people also find acupuncture helpful. The nice thing about both of those is that the side effect profile is quite favorable. And so many people feel comfortable trying them and then, after several sessions, deciding whether it's effective for them or not. When talking more generally about how we can use different approaches for treating pain, it really depends on what kind of pain we're talking about and what is causing it. That tends to be a common theme that I think we're hearing from all of our panelists who try to understand what is leading to that issue in the first place. And pain is a complex one because there are so many factors that can contribute to how we perceive it and how we experience it. When we think about pain pathways in a very traditional and very simplistic sense, we think about it like somebody is pinching my finger or stepping on my foot. That is activating receptors there. That signal is then getting transmitted up that limb to the spinal cord, up to relay centers in the middle of your brain, and then out to the higher, more evolved areas of the brain where we actually sense and experience pain. But we can also all probably imagine two different people that experience pain a bit differently. Like, for example, maybe one person in a situation where they're having their blood drawn or they get their finger pinched, they experience a certain level of pain. And maybe there's a second person who is undergoing the same thing that experiences a much higher level of pain. And that's because there's actually quite a bit of central processing that occurs along the way that's not accounted for by that very simple transmission of that signal. And so different people experience pain in different ways. And when we just think about it in the most simple way, we can understand there are a lot of different places and a lot of different ways that we can interrupt or influence that signal. One simple example that many of us might be able to relate to is most people, when they take their children to get vaccinated, for example, we usually distract them, or people usually distract them. And that's because if you pay attention to something or you attend to something, you're more likely to experience pain at a higher level and also for longer than when you're not attending to it. Acupuncture. We know, I mentioned acupuncture a couple minutes ago. There are suggestions that it may be helpful in decreasing peripheral inflammation when done at certain sites. And we also know that acupuncture stimulates the central nervous system to release something called OLP1, or opioid-like peptide 1, that actually simulates and binds to receptors similar to opioid receptors. And so those are a couple of the proposed mechanisms by which acupuncture can be helpful for pain, both peripherally and then also centrally. Massage therapy can be helpful for some people in relieving muscle tension. And then things like stress or the internal stress response can also influence how we perceive pain. And cognitive behavioral therapy has been long recommended for treatment of chronic pain as part of a comprehensive approach. And therapies like mindfulness and meditation can also be helpful, and the science behind those has only gotten stronger in the last couple of decades. So a long winding answer to say that the right approach for you as a person really relies on understanding what is contributing to your pain, which are within your control at all, and then trying to address those. The nice thing about the modalities that I just mentioned is the side effect profile is quite good. So many of them are tolerated very well by many or most people.
Thank you so much. I really agree with you. It's once you explain to patients how complex the perception of pain is, they do have a better appreciation of just how challenging it can be to treat as well. Dr. LeBlang, this next question will be for you. Is it possible that the ultrasound beam is able to reach nerves anywhere in the body? And also, can you just describe to us again how it's not dangerous to healthy tissue?
Sure. Thanks for the question. So it turns out that bone absorbs the energy from the ultrasound beam 20 times as much as soft tissues. So if you think of arthritis, any nerve that's adjacent to a joint is the one that causes the pain, which makes it especially attractive to treat any nerve along a joint. So in addition to the facet, research is ongoing with looking at nerves around the knee, an SI joint, and we look forward to doing more studies. But in theory, we can ablate any nerve that's adjacent to a bone. Having said that, one area that we're a little bit cautious about is the spine, and unfortunately, a lot of breast cancer metastases occur in the vertebral bodies. That may be a little bit harder to get to, but a lot of technological advances are being explored to try to reach that safely. And again, because the bone absorbs so much heat, any nerve along the bone can in theory be ablated with this technique. Mm-hmm. And in terms of it not damaging tissues along the way, if you have, let's say, 200 beams coming out from the ultrasound transducer to meet at that focal spot, you can think of it that each beam by itself is not strong enough to do anything. Only where the beams converge at a focal spot will they converge and actually heat the temperature to that 60 degrees Celsius, which is enough to kill anything, just like RF ablation or other modes of heat therapy that's used. So again, each individual beam is not strong enough, but where they converge or where you can create that physical effect, that's where you get the heat. So anything along the beam path is safe.
Wonderful. Thank you, Dr. LeBlang. The next question is going to be for Mr. Ruby. So a lot of people have concern, or a lot of patients have expressed concern to me that they are reluctant to use medical marijuana, to use CBD, because it might interfere with their ability to work. And in spite of, doing our best to educate regarding the differences between CBD and THC, what do you normally counsel people in terms of the most effective way and the safest way to take cannabis or to use cannabis medically?
Thank you for the question. The best way is to start low and go slow. Start with as low dose as possible and increase it slowly over time. For people who are just taking CBD, the effects of taking it are usually not felt until 10 or even 14 days after taking a consistent dose. If you're starting with CBD, you could start as low as 10 milligrams and try to work up from there. I usually try to counsel an adult person to try to get up to 50 milligrams a day, taking some in the morning, some at nighttime. But again, you want to start low, go very slowly when it comes to, especially when it comes to the THC side. If you're ingesting it, it's going to have a very, very different effect than if you're inhaling it. So that's another situation to be mindful of. If you're vaporizing or smoking the flower, you're going to have an almost immediate effect. If you're taking a pill or a tincture and swallowing it, it's going to could take 2 to 3 hours depending on when your last meal was. A very common mistake is somebody eats a little bit of THC, waits 15 minutes, they didn't feel anything, they eat a little bit more, wait another 15 minutes, they don't feel anything. Now they're taking double the dose and it hasn't even been an hour, they still don't feel anything. Then they take more and now the first dose starts to kick in. So now they're in a very overdone dose. Now, the good thing is you're not going to kill yourself if you overdo it. If you take 100 milligrams and not 10, you're not going to die. So you certainly need to be mindful of the psychoactive effects on that. You probably need to lie down and go to sleep. So start low, go slow, and be mindful of the delivery methods because they're going to have a different effect on the body.
And the next question I'm throwing out to the group because I'm not sure which one of you may have the answer. So one viewer is asking about DMSO used both topically or as an edible, who claims that it helps them with pain as well as sleep duration. Does anyone have any insight or opinions on that?
I haven't really used it in my practice, but maybe a couple of words. It is thought to have, it does have anti-inflammatory activity. It is generally, from what I know, used topically, and it's been used for pain and inflammation in the bladder, and also some signs show that it might be helpful for arthritis, whether osteoarthritis or perhaps autoimmune causes of arthritis. But I can't summarize the evidence and give a recommendation. So I would just suggest caution if something is not commonly used off-label or is not approved for a certain indication.
All right. So for Dr. Bharara, how long does it take to recover from a regenerative medicine procedure? And I think we covered this a little bit, but a viewer wanted to know if Medicare is covering, not just commercial insurances. I'm not sure if you know the answer to that. We probably do.
There is a thought that usually Medicare and TRICARE cover similar procedures. But as of right now, Medicare is not covering what TRICARE is covering. So I would imagine over the next year or two, we're going to see that Medicare starts picking some of these procedures and actually covering them. They usually don't look at these procedures. They only do it once a year. So we're probably not going to see that change over this year anyway. So that being said, the recovery time on a regenerative medicine procedure depends on what you're treating. So if we're treating a joint, such as the knee, many times it's you take it easy for the first 2 weeks after the procedure, and then you kind of get back to doing everything you want to do. Most people go back to work the next day. It's a fairly easy recovery time. For treating a disc in the spine, it's a little more complicated of a procedure, in which we're going to have to go into actually place the needle into the disc and then place the regenerative medicine substance that we decide to use, such as stem cell or PRP or whatever other substance we decide to use. And that does cause an increase in pain for a few days after the procedure. And then the healing time and then there's some healing time and increased pain that lasts maybe anywhere between 7 to 10 days. And most people will return back to work in about 7 days, and we'll see the benefit anywhere between the 4 to 8 week mark. And then we'll start the healing process from there. So the recovery time depends on the patient, but it's significantly less than any surgical time, and usually anywhere between just a day or two to a couple of weeks.
Thank you, Dr. Bharara. The next question is for Dr. Gupta. I'm wondering if you could, so you mentioned that, stress and anxiety can contribute to pain. Can you just explain a little bit further about how you usually approach the management of that, perhaps not using conventional, pharmacologic treatments? And then this is my own question. Do you ever incorporate nutrition counseling in terms of a more non-conventional, it should be conventional. Unfortunately, I think we all would agree that it's not yet a part of mainstream medical education.
Definitely. Your first question was about the impact of stress and anxiety on pain perception. And we talked about how pain works a bit. A lot of what happens centrally can be impacted by certain emotions. So to put it simply, when we're anxious or scared or afraid of a certain situation or in a certain situation, or maybe even all the time, we tend to activate certain areas of the brain. We tend to activate more primitive areas of the brain, more lower down areas of the brain that we refer to as the monkey mind, because they're very similar in more primitive animals. Areas like the amygdala and other associated structures. And when we do that and we activate those systems, we literally upregulate, we increase the pain signals that reach the higher levels of our brain. So that is a known effect. On the other hand, with the opposite, so if somebody is relaxed or in a more restful state, we can actually downregulate or decrease the amount of pain signals that go up. And so that's part of the reason that cognitive behavioral therapy has been a long-standing tool to addressing chronic pain. Not acute pain, but chronic pain. Once you've been in pain for week after week, month after month, year after year. Mindfulness and meditation, there's more and more data on that having a measurable impact on how we perceive pain. And what we see in people who practice mindfulness on a regular basis, we actually see structural and functional changes in the brain that back that up. So we see people's, the prefrontal cortex, the area right behind your forehead, that's the most highly evolved area of the brain. That's basically what makes us human. It's what allows us to regulate our emotions. It allows us to regulate our thoughts, regulate our actions. And that area actually grows and gets better connected and more active in people who practice mindfulness. And then we actually see that those more primitive areas of the brain, they can actually shrink in volume and get less well connected and less active. So we can see it both at a behavioral level and also at a measurable pain level, and then all the way down to the anatomical side. And those are just things that we can't accomplish through a medication right now or a supplement. To your question about nutrition, that's one of my favorite things to talk about. You know, the way we eat and drink influences so many different chronic illnesses. And if you look at, you know, maybe not as much things that we're talking about today, but if you look at the leading causes of morbidity and mortality in the US, at least 5 of them are at least somewhat preventable by optimizing what we eat and drink every day. So it's a very relevant part of health. I think it lives at the core of health, and it should be in primary care. And so you should definitely seek that out if you're not getting it where you are.
Excellent. Thank you, Dr. Gupta. All right, so we're going to try to fit in these last 2 questions. This one will be for Dr. LeBlang. A viewer is asking very specifically about focused ultrasound in the treatment of pancreatic cancer. And then on that note, what are the most exciting new areas that focused ultrasound is looking at to alleviate pain?
So yes, thank you for that question. And the Focused Ultrasound Foundation investigates research and clinical adoption of focused ultrasound with a wide variety of disorders. And pancreatic cancer is one of our main focuses. But I'm going to actually make an analogy between pancreatic cancer and breast cancer, because I want the audience to know that this is not just applicable to bone pain for metastatic disease or just the degenerative disc disease, but we actually have about 9 or 10 clinical studies going on right now, and whatever I say for breast is applicable to pancreas right now as well, where we can either do thermal ablation of the primary breast cancer, so a way to non-invasively destroy the breast cancer without doing surgery like a lumpectomy or a mastectomy. We can do targeted drug delivery, so we can actually put medicine inside a small smart particle, inject it, and then we can make it release just in the area of the breast tumor by letting the focused ultrasound beam open up those smart particles to deliver much more medicine right to the tumor and avoid systemic toxicity to the body. Again, same thing with pancreatic cancer. We can also use radiation sensitization, which is now in a clinical trial, where if we do focused ultrasound to the tissue, it primes it up so that you can maybe use less radiation and get less side effects and have the radiation be more efficacious. And one last clinical trial that's really exciting now is for patients with HER2-positive brain metastases, where we're doing targeted drug delivery across the blood-brain barrier. So normally the blood-brain barrier, just to make it super easy, is we can't get medications across this blood-brain barrier into our brain for Alzheimer's disease, metastatic disease, but focused ultrasound can open up the blood-brain barrier in a very targeted area. So we can give Herceptin, open up the blood-brain barrier where the brain metastases is. We can actually watch and tag the Herceptin with a radio-labeled pharmaceutical and watch how more medicine is getting into the brain tumor itself where the metastasis is and not into the rest of the normal brain. So again, we're attacking cancer on multiple fronts with multiple mechanisms of action of focused ultrasound, and all of that is applicable to breast cancer and other cancers like pancreatic cancer.
It's amazing. Wonderful. Okay, Ethan, I think maybe last question is going to go to you. And often, neglected group or population who is in chronic pain is children. Can you tell us a little bit about the use of cannabis and medical marijuana in kids? Is there an age that it's too young to start? Do you have any idea what the American Academy of Pediatrics thinks about it?
Thank you for the question. I will say my father, who is a practicing pediatrician of over 40 years, who actually recently retired, he was one of the first certifying pediatric doctors for kids under 18 in Massachusetts. And at one point, all 100 patients that were in the system, he was one of the 2 doctors that had to certify. So from a pediatrician's perspective that's been doing this a long time, he was very supportive of it. So 18 is usually the age. You usually see cannabinoids being used in children under 18 more for epilepsy and some of those conditions. I have not seen a lot of it on pain treatment sides, but I'm sure that there is some benefit. You really want to be careful. The child's brain is still developing, and a lot of the harm that has been attributed to cannabis really would be more significant or impactful in a non-matured brain or a brain that's still evolving. CBD would certainly be much more benign. If you're interested in working with a cannabinoid on somebody under 18 years of age, you do want to be very, very careful with the THC component. And to my knowledge right now, it's really only being used to address epilepsy and seizures.
Right, exactly. Okay, well, I think that is going to pretty much conclude our panel discussion. Thank you all so much for joining and for submitting your questions. They were excellent. I'm going to turn it over back to Yonni to see if she has any other closing comments. Thank you all so much.
Thank you so much, Natalie. That was brilliantly done, of course. I want to thank all of our panelists again for all the wisdom you shared today. We will be sharing contact information for everyone. So if you'd like to learn more, have any unanswered questions, want to explore some information about Breast Cancer Alliance or any of the other organizations on here, we encourage you to do so. And we all hope you learned as much as we hoped you would today. So thank you again for being here, and enjoy the rest of your day.